Very good. Thank you very much for allowing me to join this meeting as well. Appreciate that. We're going to talk about the survival benefit, knowing that no study so far has ever been designed to look at the survival benefit, and everything that we know about the possible survival benefit of JAK inhibitor is observational or a retrospective analysis at best. But let's first look at the update of where we are with different JAK2 inhibitors. There are 10 of them that have been ever tested in a clinic, and they are listed here, and this is, to my knowledge, the up-to-date status of each of these. The last three on the slides are of interest. The last one is Ruxolitinib that is approved for myelofibrosis, and now the study in a second-line PV is going to be presented in the summer. This is so-called response study, where the Ruxolitinib was compared to best available therapy. We'll look at that, but I'd like to focus on two other JAK inhibitors. This is next to the last and the one above, PACRITINIB and Momelotinib. These are other JAK2 inhibitors in phase 3 studies, and just let's take a look at the design of these studies to know what is going on and why. We talked about Momelotinib earlier today. Dr. Cervantes gave us a nice summary of possible benefits. This is a blinded study where Momelotinib is compared to Ruxolitinib in a frontline setting for patients previously not treated with JAK inhibitors and having platelets above 50, where the two drugs are compared head-to-head over 6 months' time, with the goal to see that Momelotinib is as good as Ruxolitinib in a spleen response and a symptom control, and providing benefit in anemia, making people transfusion independent, which was suggested from the phase 1-2 study. That's a pretty large study, about 420 patients, one-to-one randomization, and I encourage everybody to participate in this study as well. The other medication is PACRITINIB. This is a little different than JAK inhibitors. It is also inhibiting the FLT3, and because of that, we suspect that the DLT that we observed is unusual for other JAK2 inhibitors. This is a GI toxicity. It does cause some nausea, vomiting, and diarrhea, which you can control with the antidiarrheals or anti-nausea medications, but it does not cause, because of that, too much of myelosuppression. You don't really reach the dose where there is a myelosuppression, and there was also summary earlier today about its efficacy. This study, PERSIST-1, is underway throughout the world, where patients, regardless of the platelet number, even platelets as low as 10, can participate in this study. This is a study for previously not treated patients with JAK inhibitors, and it is compared to best available therapy excluding other JAK inhibitors. So it's reminiscent of Comfort 2 study, the JAK inhibitor versus best available therapy, but no discrimination based on the platelet numbers. Anybody can join, and the goals are to see about the spleen and symptom improvement. The second study of the two phase 3 studies that are underway for PACRITINIB. This one is called PERSIST-2 and mostly based in the United States, but it's spreading throughout Europe as well, and may some of you already participate in this. This is to explore the ability of this medication to provide clinical benefit in patients with low platelets. So it's only for patients with low platelets, below 100,000, previously treated with JAK2 inhibitors or not, doesn't really matter. And it's comparison of PACRITINIB to best available therapy, where best available therapy can include the JAK2 inhibitor. So previously exposed to JAK2 inhibitor, never exposed to JAK2 inhibitor, and the JAK2 inhibitor can be used as a comparator. 2-to-1 randomization, and the primary endpoints, as usual, are spleen and symptom control. So we have two phase 3 studies with PACRITINIB underway, and one head-to-head comparison of Momelotinib to Ruxolitinib, and maybe we'll have more than one JAK2 inhibitors to cover more patients in the first and second line setting with myelofibrosis. Now, to go back to survival, we all know this risk classification. Just to show again that we are focusing in our studies usually on high risk and intermediate 2 risk patients. Some of the studies now also allow intermediate 1 if they have symptomatic disease. But this was such a design because at the beginning of development of JAK2 inhibitors, we did not know what to expect, and the regulatory bodies always wants us to study new medications in the worst patients. So this was intermediate 2 and high risk group. with a low probability of long-term survival. Now, what is important to understand when we're going to go now into analysis of possible survival benefit of JAK inhibitors is that for this particular group of patients, and this is excellent work by Dr. Cervantes and the colleagues in Europe in particular, the analysis of survival of the patients by risk assessment over time. That was a paper that clearly showed in Journal of Clinical Oncology in 2012 that for this group of patients with advanced features, there was no change over time. There was no change at all that any of the therapies that we have implemented from 1980s to now did not actually make any difference for overall survival for patients with intermediate to or high risk. So what are we talking about? I'm glad you all finished the lunch. So we're going to show a couple of pictures. This is what we are talking about. This is a patient who is doing well. He's traveling around. He has a big spleen. He has myelofibrosis. The spleen was actually taken out. He got better. And this was about 7 years ago. Well, the disease does not stop. This is when he came to MD Anderson to participate in a phase 1/2 study 5 years ago. We all recognize what happens with these patients. We know from our own experience, body wasting. He had big liver by now because it does go up after spleen removal. So he needed help. He was dying. Now let's go back to the survival then. So this is the up-to-date analysis, not published yet, of the COMFORT-1 study after 3 years of follow-up of the 2 randomized groups. Patients that were randomized to Ruxolitinib are in upper curve, and those in lower curve are those that were randomized to placebo, knowing that 75% of the placebo-treated patients crossed over to Ruxolitinib after an average of 41 weeks. Despite that, we see survival. But we need to know that the survival was not the primary endpoint of this study. This is simply an observation. When the analysis for safety was made at pre-specified time points, then there was an observation that people actually have a difference in survival. It was not designed by statistical methods, by number of the patients, to say whether patients treated with Ruxolitinib or treated with placebo at the beginning, despite the crossover, would live any different time period. So it's an observation that we have learned about as we continue to follow these patients over time. Now, there are statistical methods to account for the crossover. If 3/4 of the patients cross over from placebo to Ruxolitinib, that certainly has an impact on the overall survival of that group. The curves that I show are intent to treat analysis. You don't change assignment of the patient based on the crossover. They are always in the placebo-treated group, regardless whether they cross over to Ruxolitinib. So these are some of the examples of statistical analysis that we have shown in ASH that would substantiate the benefit of earlier exposure to Ruxolitinib rather than later. Despite the crossover, there was this change in the survival. And the one that probably makes most sense to present, and it's clear to see it in a curve, is this one, which is rank-preserving structural failure time. And I had to spell it out for me to say, because that's what the official actually name of the statistical analysis is. What we show here in a black curve is what would happen with the patients if they did not cross over to Ruxolitinib. And now it's much clearer here to see what would be the difference in survival in that case scenario. So the crossing over to Ruxolitinib changed actually the outlook of the patients that were initially randomized to placebo. So what happened to our patient? He was actually part of the study. I don't have his whole body, I'm sorry. But you can appreciate the change, right? So in our own experience from the phase 1 study, we have about 107 patients included in a phase 1 study. The average follow-up is about 5 years now, unpublished. About 22 patients are still on the therapy after 5 years, so 20% after 5 years. We said earlier on from the COMFORT-1 and COMFORT-2 that average is about 3 years, 50%, right? So there is a dropout over time, but there are long-term patients that will benefit for many more years. Now, I showed this before. This is the same type of analysis. Observation in the COMFORT-2 study, Ruxolitinib versus best available therapy. with the crossover, there was 2/3 of the patients on the best available therapy arm were actually exposed to ruxolitinib, and here we see about half reduction or 50% reduction in a risk of death in the ruxolitinib arm. I can't really tell you, usually people say, how much time did we gain? Well, we didn't reach 50% of people dying yet, but there is a 50% reduction in the mortality overall during the conduct of the study. Applying this analysis that I showed before, in overall analysis of Comfort 1 and Comfort 2, all the patients together, so several hundred patients on each of the arms, either the ruxolitinib in orange or dark blue is control. The light blue is the one analysis where there was no accounting for the crossover. So now the survival advantage is much more clear in this particular analysis. And if you look by IPSS, that was the purpose of showing IPSS at the beginning, to understand that there is a difference between high risk and intermediate 2 risk. What happened here is we moved patients up. We moved the patients from the high risk to expected survival for intermediate 2. They basically go up in time and live longer for what would be expected for the less riskier group, if you like. Now, the most important paper came recently from Dr. Passamonti, and maybe in discussion we'll look at that. This was shown already a couple of times, because what is the difference here between this analysis, comparing the Comfort 2 cohort of ruxolitinib-treated patients with the DIPS cohort, the cohort that was used for development of the prognostic scoring system, is that these patients were retroactively looked at and followed from the time of diagnosis. It's not from the time of enrollment in a study, which there is always this time bias when the groups enrolled at a certain point in time. This is from the time of diagnosis, and there is significant, obviously, here a difference in numbers, and this is the curve that we have shown, and maybe we'll discuss this later. Appears to have imminent or immediate impact on the survival right at the beginning. But this is the difference is right from the start seen between the two groups. And that's another patient. Most of the patients that we see at MD Anderson are really advanced, like I have shown here. This is another patient who came in a wheelchair, and I just saw him in January last time, and he is a happy camper. Now, why is this possible, and how is this possible? We talked about causes of death in patients of myelofibrosis. Most of the people die from leukemia as a single agent, single reason, but that's overall about 15 to 20% of the patients. So about 80% of the patients die from progression of myelofibrosis. And this is related to progression in a spleen, progression in cachexia, body wasting, and this is something that we can affect. So this is anti-proliferative and anti-inflammatory effect of the ruxolitinib that are combined together by inhibiting the JAK pathway in general. And this is outlined in this cartoon. So it's a combination of anti-proliferative and anti-inflammatory benefits of all together. And on the last note, just to show again what was shown before, to understand possible impact of molecular genetics on the outcome, it does not appear to be the case, as Dr. Vanucchi already showed, because we keep trying to find out why some patients respond to different extent, and we don't have a real explanation yet. What is the biological difference between the responses? And not to go through all these slides, but they were shown before, the most important one is here, that there is a survival benefit regardless of the mutational status of the patients related to these 4 mutations. Basically, patients benefit across the board. And in the summary, there was a decrease in death of patients with high molecular category of 43%, so which is similar to the others. So with that, I would conclude my presentations. Thank you very much.